recording and slides will be made available no later than the end of the week. This will be done through an email. So one more time, the recording and the slides, we will be sending them, making available to you guys either after the presentation, but for sure before the end of the week. We hope you guys enjoy the presentation. So as you guys are all aware, diabetes is a serious condition. According to 2018 UDES data, diabetes poses a unique challenge for HRSA Health Center programs because 1 out of 7 patients has diabetes, and nearly one out of those 3 has uncontrolled diabetes. To elevate the national conversation around diabetes, 14 national training and technical assistance partners organizations formed the Special and Vulnerable Populations Diabetes Task Force to engage health centers, primary care associations, and health center control networks to increase knowledge of effective strategies that address diabetes among people experiencing homelessness, residents of public housing, migratory and seasonal agricultural workers, school-aged children, older adults, Asian Americans, Native Hawaiians, and Pacific Islanders, LGBTQA plus people, and other health center patients. We would like to disclose that this learning collaboratives have been sponsored by HRSA. These, as you are the logos for the 14 national training and technical assistance partners that make up the task force. The following are the staff in charge of putting together the 4-session learning collaboratives. We have Albert Ayazen, Associate Director with APSHO, with Association of Asian Pacific Community Health Organizations. We also have Cindy Selmy, Executive Director of Health Outreach Partners, myself, Hansu Ibarra, Program Director at MHP Salud, and we also have Dr. Irene Hilton, Dental Consultant at National Network of Oral Health and Access. As a reminder, in this 4-session learning collaborative, health centers will engage in national discussion on how providers and their enabling service staff can assist in improving health outcomes, including diabetes for special and vulnerable populations. Throughout each session, participants will hear from health center medical, nursing, and enabling servicing staff who have firsthand experience addressing social needs barriers. Examples will be community partnerships, food pantry, transportation, cooking classes that impact diabetes outcome in under-resourced communities. We would like to invite you guys to go ahead and visit our website. Here, you will have access to previous presentations, sign up for future events, and stay up to date with everything we are doing. Also, in our website is our compendium of resources. The compendium of resources highlight key diabetes information in order to address the unique needs of people experiencing homelessness, residents of public housing, migratory and seasonal agricultural workers, school-aged children, older adults, Asian Americans, Native Hawaiians, and other Pacific Islanders, LGBTQIA plus people, and other vulnerable populations. And I believe the website was dropped on our chat box. So if you are interested, by all means, we welcome you guys to go ahead and take a look. Before we get started, we would like to take the time to do a dinamica, a little icebreaker. At this time, I would like to ask you all to share with us in the chat box a healthy alternative to a common dish. We have provided an example to you guys. The example is regular rice versus cauliflower rice. The picture here shows you that 1 cup of regular rice is equivalent to 230 calories versus 1 cup of cauliflower rice, which is equivalent to 40 calories. So at this moment, we would like to go ahead and encourage you guys to share with us a healthy alternative to a healthy dish. You can go ahead and share your name, your title, your role, the name of your organization, and then if you can go ahead and add that alternative dish. We'll go ahead and read 2 to 3 examples. I see one that has already came in. I see here it says chickpea pasta opposed to regular pasta. Yes, that's a good one right there. I also see zucchini noodles instead of spaghetti. That is one that I've tried myself, and it's very, very delicious. Zucchini noodles instead of the spaghetti. See if we can get 1 or 2 more answers. We have our own Cindy. She has a grilled fish as opposed to fried fish. There you go. The little things like that make a big, big difference. Well, I will go ahead and welcome you guys to continue sharing your healthy dishes alternatives in the chat box. Be on the lookout. Someone might suggest something that you hadn't thought about. So before we get started today, or the objectives for today are going to be as follows. The first objective is to describe the role of enabling service staff can play on the healthcare team. We're going to go ahead and also define return on investment, ROI, as it relates to enabling services, enabling service professions. We're going to go ahead and end with presenting real life examples of an enabling service integration into a clinical team. According to the Uniform Data System, the following are full-time equivalent enabling service staff categories. While these are the accepted categories, enabling service staff have multiple other titles. Some of these titles have been combined with one of the accepted categories. The services range from clinical to non-clinical work. The first category that we have here is going to be the community health worker. Many times, our members of the same communities they serve, they work in association with local healthcare systems to reach urban and rural communities. Some of these other titles for this position are CHWs, promotores de salud o promotora de salud, and also family resource coordinators. We also have case managers. These are staff who assist patients in management of their health and social needs. Things such as setting up appointments for the diabetic patients, as well as following up for future appointments. Different titles for this could also be care coordinators or health coordinators. We also have the title of patient and community education specialist. These individuals' role is to teach and encourage healthy behaviors that promote wellness. They educate the community on the risks and may offer tips to manage chronic disease. Titles for this would be things such as a peer educator, health educator, and a health coach. Another category that we see here is outreach workers. There's going to be staff under this category focused on offering available resources. They do case findings and community education. They will go out to the community and offer resources in places such as churches, community assemblies, school meetings, etc. Titles for this position would be, other titles would be outreach community health worker, as well as an outreach and enrollment worker. We also have the eligibility assistance workers. This staff are the ones who provide assistance in securing access to health, social services, pharmacy, and other assisting programs, including Medicaid and Medicare, health insurance marketplace, WEEK, supplemental insurance income, food stamps through SNAP, temporary assistance for needy families, and other related assistance programs. Titles for these positions range from navigator to eligibility assistance specialist, and could also include a public benefits assistance. Another position is going to be the interpretation workers. These individuals assist with the translation and interpretation services. So you have people working in the non-clinical aspect, which will be assisting with translating letters, assisting with application completion, and you also have your interpretive workers that work with the clinician team, which are going to be assisting with translating medical instructions, also assisting with communication between the physician and the patient. The last category that we have here is the other category. The UDS provides this section to report all other staff performing enabling services not described in any of the other categories. This category may include medical legal partnership staff who provide legal advice, advocacy for the patients, and services that combat health-harming social conditions and health-harming legal needs, such as housing, public benefits, insurance, and domestic violence. Enabling service staff have been identified as helping increase patients' education levels, self-sufficiency, engagement, empowerment, and medication adherence. They've also been identified in helping improve in patients their health outcomes and attendance to medical appointments. They've also been identified as contributing to sustainability of programs and professions in the development of culturally appropriate tools and resources. Today, we're going to go ahead and highlight the role of the CHW in diabetes management. A community health worker, CHW, is a trusted member of the community they serve. CHWs in both clinical and non-clinical settings CHWs work in both clinical and non-clinical settings and provide health education and referrals to local organizations that assist with health and social services. CHWs meet participants where they are, either at home, at work, or out in the community, to better reach participants and meet their unique needs. CHWs are commonly bilingual, which helps to better connect and communicate with migrant farmer communities. While their primary role is linking vulnerable populations to the health system, additional roles can include cultural mediation, culturally appropriate education, care coordination, case management, systems management, navigating, coach and social support, advocacy, capacity building, and outreach. Through these roles, CHWs offer support to participants with diabetes and or at risk of developing diabetes in a unique, culturally appropriate manner. Due to the intimate, close understanding of and trust from the community they serve, CHWs have a unique ability to build strong relationships and effectively address challenges individuals face when trying to manage chronic conditions such as diabetes. CHWs also conduct home visits and speak one-on-one with participants on the importance of proper nutrition, physical exercise, and disease management. Overall, CHW's interventions have successfully demonstrated success in improving health outcomes among individuals diagnosed with diabetes and at-risk individuals to prevent developing any of these conditions. And the next slide right here shows you those different types of roles that I mentioned about the CHW, and it also gives you sub roles to give you further detail as to those categories. So it has a cultural mediation, and then sub roles to give you more detail as to what that means here in this chart. So in the first presentation, we introduced the quadruple aim, and it consisted of improving population health, reducing cost of care, enhancing the patient experience, and improving provider satisfaction. CHWs are uniquely situated to assist in all of these four categories. The following are real life examples of the impact that the CHW profession has directly with their patients. So the first category, we have improving population health. In this, we see one of the most commonly reported positive health outcome in CHW-led diabetes intervention is the improvement stabilization of A1C levels reported in patients. When it comes to reducing cost of care, studies have reported that CHW-led interventions have resulted in increased physical activity of participants, which is a key factor in preventing and managing diabetes. Under enhancing the participant experience, we have that frequently reported is the experience in participants' knowledge regarding how to prevent and manage diabetes. Results have been significantly better when participating in CHW-led interventions as compared to control groups. And we also have improving provider satisfaction. Studies have shown that CHW-led stress management exercises are successful when incorporated into diabetes education and its management classes. But not only does the CHW or the enabling services, benefit the individuals, they also benefit communities and organizations. And here we have some of those benefits. We have reducing disparities in prevalence of type 2 diabetes, in complications in underserved populations have been linked to poor quality of care, including lack of access to diabetes management programs. By providing access to cost-effective care, CHWs have been able to successfully address and mitigate these health disparities. They've also assisted with reducing ER utilization and medical costs. CHW interventions have resulted in the decreased rates of unnecessary ER usage and the decrease of medical costs. And this is because the CHW can go there and assist those individuals by teaching them some self-care methods, making them more aware of their conditions, which would prevent them from utilizing health services that maybe they don't need to utilize, because self-care can go ahead and cover that. And we also have improving patient-provider coordination. CHWs have also shown positive results in enhancing coordination between patients and providers, increasing medication adherence and follow-up visit attendance. And then the next slide here is a fact sheet published by a nonprofit organization in California back in December 2021. It shows that integrating the CHWs into the healthcare delivery teams have been valuable during this COVID-19 pandemic, as CHWs are able to provide individualized um, services to heavily impacted communities. So enabling services address a combination of social determinants of health and barriers to access to primary care. They intend to reduce health disparities. Their impact can be seen in this following four categories. So the first category that we see the impact of enabling services is through health outcome. So how does enabling services impact health outcome? First off, health outcomes measure a change in the health status of an individual or a group, which can attribute to intervention. Positive health outcomes include being alive, functioning well mentally, physically, and socially, and having a sense of well-being. Negative outcomes include death, loss of function, and lack of well-being. There is evidence demonstrating how enabling services programs have positive health outcomes. A recent intervention led by either HIV positive or HIV affected CHWs in 3 southern Western communities sought to decrease stigma around HIV and increase knowledge on HIV and perception of risk. Results of the intervention found that the stigma decreased and knowledge increased among 579 underserved Latino adults impacted by the intervention. This further proves that combined with treatment and care of an HIV care team, CHW-led interventions, activities, education, and community-level support are a powerful strategy to preventing HIV. Another impact that enabling services have are in service delivery and in quality of care. Enabling services have a positive impact towards the delivery of services by ensuring that the patients understand what is expected of them and allowing them to voice out any concerns. This return also causes a positive effect in the quality of care being experienced, since there's communication and understanding between the medical providers and the patients. CHWs can help make healthcare systems more responsive by communicating information from the community back to the healthcare providers and vice versa, thus improving service delivery and quality of care. A CHW working with a diabetic patient can ensure that the patient understands the risk of mixing medications and teach them the ways to stay active, as well as provide healthy alternatives for common dishes. They can also listen to any concerns that the patient may voice and communicate them back to the healthcare system. CHW programs that educate on prevention and management of diabetes have shown at least one significant positive outcome, ranging from lowering HbA1c levels to improve self-reports of dietary changes. And we also have a fourth category that is impacted by enabling services. This category is return on investment. The fourth category, as I mentioned, is return on investment. A return on investment, or an ROI, calculation is a total value of benefit, profit, resulting from a program intervention divided by the total program cost. Every dollar invested there is a benefit created. And here we have the chart that shows you the total value of benefits divided by the total cost, and that gives you your return on investment. Remember that I mentioned that not only does the individual benefit from the work that the enabling services staff do, but also the community and organizations. Well, return on investment assists with capturing all of these benefits. A return on investment calculation is the total value of the benefit profit resulting from a program intervention divided by the total cost. An example, or we have different examples there. An example of an ROI score of more than $1 tells you that the program calculated benefits outweigh the cost. A positive ROI may indicate benefits like increased productivity, efficiency, and improvements in quality of patient care. A return of investment of less than 1 tells you that the program costs more than the calculated benefits it is producing. Now, a program who scores less than 1 or doesn't necessarily mean that it's an unsuccessful program. There are benefits we simply cannot quantify or might have missed. A return on investment of 1 tells us that the cost benefit is equal to your program costs. So why do we use return on investment? We use it because it estimates direct financial impact, It is versatile. It can be individualized. We can use it to as a financial and non-financial component, like the cost of doctor visits and less sick days due to lower A1C levels. It is relatively easy to understand and use, and it supports sustainability by showing how funding the program creates its own savings. Understanding and participating in return on investment process arms you with the knowledge you need to show enabling services staff as a key to serve your communities. The current national attention paid to improving health outcomes and quality of care while also containing costs makes a positive return on investment result even more significant. Measuring return on investment on CHW-led programs and sharing the results contributes to the growing body of evidence that investments in these programs are both impactful and financially suitable. Return on investment results additionally provide a great snapshot of information to share both with stakeholders and the community to demonstrate both social and fiscal responsibility. So community health worker and other helping professions tend to think with their heart. A common quality of a CHW is compassion. They see the community need and they want to help as many people as possible. But many others think with their pockets or their wallets instead. Return on investment allows us to persuade those with the wallet mindset and show the worth of a community health worker. The following here are examples of how the incorporation of enabling services to the medical team have shown great success. So we have an example of Denver Health. They had a return investment of $2.28 in savings for each dollar spent due to the decrease in urgent care and uncompensated costs, an annual savings of $95,941. We also have another example, which is Arkansas Community Connector program. They tracked Medicaid spending of 900 patients and saw a 3-year savings of over 2.6 million or $2.96 savings for each dollar that they spent. Spectrum Health in Grand Rapids, Michigan, they saw a $2.53 savings for every dollar invested of cost for patients diagnosed with diabetes or heart failure. So community health worker programs also yield benefits as improving chronic disease outcomes can produce positive cost savings. And we go ahead and see that here. Return investment together with success stories, testimonials, and other type of data and information showcasing the great work that are being done comes together to demonstrate an overarching value of the enabling services staff. At this moment, I would like to go ahead and introduce today's speaker. Her name is Selenia Gonzalez. She is a CHW resource specialist. She works for MHP Salud, and she is here to give us her perspective of a CHW who has worked with the clinician team. So at this moment, Selenia, if you would like to go ahead and take over.
Thank you. Hi, everybody. I'm Selenia. I've been with MHP for a couple of years now. And we're going to talk about Salud y Vida. This is a program that I worked in as a CHW or a promotora de salud. So over the years, we know that MHP has developed multiple community health worker programs and to address a variety of chronic diseases such as diabetes. Salud y Vida, or Health and Life, was a program that aimed to help program participants make a healthier lifestyle decisions through CHW-led education, skill building, and support. So we had this program for 4 ongoing years. Here in the slide, we can see it says, obesity and diabetes is a pandemic in the lower Rio Grande Valley of South Texas. Those are the areas in which we work. And we can see this because we see more dialysis clinics popping up in our area, and it's a cause of diabetes. And these are just some statistics that we have to share. Can you change the slide, Hansel, please? So MHP Promotoras worked in collaboration with Nuestra Clínica del Valle. Nuestra Clínica del Valle is a nonprofit, low-cost clinic that serves the same counties as our organization does. Salud y Vida, or Health and Life, is a free program. And the requirements to participate in this program were that they were 18 years of age or older, they resided in the service counties, and they were patients with Nuestra Clínica del Valle. And that they had a A1C of an 8% or higher. Nuestra Clínica del Valle would refer us their high-risk diabetes type 2 patients. High risk meaning the 8% on the A1C test. Next slide, Hansel, please. So here you can see a picture of my coworker doing a home visit. CHWs would meet with participants, usually in their homes, and we would begin the case management services, which lasted 12 months. These home visits were somewhat, I like to say, informal, mainly all in Spanish, and informal in the sense that we would speak to the participants, well, in the language that they understood, in, what's the word that I'm saying? In a way that they understood us. We didn't use so much of the medical terms. This would help us encourage participants to share with us what their struggles were, what their concerns were. We would meet with the participants every 3 months for a whole year, and we would follow up with them in between our visits. During the home visits, we offered education on their diagnosis. We would explain the symptoms to look out for and possible complications. So this goes back to the slide that Hansel shows on the ER, like minimizing the visits to the ER. So if the participants knew what they were feeling, we would give them suggestions like, okay, maybe if you do this, this will help with the symptom you're having, which is either low blood or high blood sugar. We would discuss what they already knew about diabetes management, and then we would suggest new strategies to go over. And then we would also go over the expectations of the program. The expectations meaning that they follow up with their doctor's appointments, that they take their sugar levels every day, and that they attend our 6 classes, which was part of the program. And we'll go over that in a little bit. At every home visit, no, I'm still in the last slide, sorry, thank you. At every home visit, we would measure their waist, we would take their weight, and then we would discuss the A1C percentages with visuals, such as that one on the slide. Sometimes our participants didn't understand what an A1C test was or how it was measured. So they would think that, okay, we would call them and remind them, hey, we're gonna have your A1C test tomorrow, will you be home? That the idea that they had was, okay, well, if I eat good all day today, tomorrow my A1C test will be good. So explaining the difference between the daily blood draws versus the A1C. We would set goals with the participants at every visit, and realistic goals that they themselves would set. Something simple like physical activity, or doing a little bit more physical activity, replacing meals with other substituted meals like in the Dinámica for today, or overall less of or more of something. We would also go as far as to set alarms for the participants on their phones, just to remind you, you have an appointment this day, don't forget, or this is a time every day, it's gonna ring at this time, it's time to take your medication, more for our elderly participants as well. The beginning of our case management services, each participant would get a glucometer and strips if they didn't have one. And this was to encourage them to document those days that they had the high blood sugar levels and to think about what they ate that day. So they could themselves, be cautious of, okay, if I eat this, I already know I'm gonna feel of a certain way, so they would avoid it. Next slide, Hansel. Coordination of services. This is somewhat of a timeline of how the program worked with Nuestra Clínica del Valle. We would meet with the staff at the clinic, and the staff would include social workers, the director, or the doctors that had patients with Salud y Vida. And we had access to the clinics, well, not all the patients' information, but some information to include the day that they went, what weight they had, their A1C. That way we could compare to our last visit. And in these meetings, we would discuss the patient's individual cases and how having a CHW affected the growth or the change in the participant. or even the doctors would tell us or suggest, how about trying this now with the participant, to see if they were making change. Next slide, Hansel. So as we had discussed with the home visit slide, the participants were encouraged to participate in our CHW-led classes. And the name of it is Diabetes Self-Management Education Classes. It stands for what we call DSME. So this is the ongoing process of facilitating the knowledge, skills, and the ability necessary for diabetes self-care. These classes consisted of 6 2-hour CHW-led classes. We would meet once a week, and it was, like I said, very informal. We wanted them to feel comfortable. We wanted them to participate. And the topics were understanding their diabetes, what happens to the body, how medication affects the body, storing their medication, avoiding certain foods depending on the medication that they were taking, incorporating physical activities, and also the healthy plate. We would go over the healthy plate and suggestions on how to fill it with different things to accommodate to the children in the home as well. We explained the A1C, how stress affects their diabetes, and as well as symptoms, complications of not managing it, and what to look out for if their levels were high or low. So the role of the CHW is to navigate the curriculum that we had using the method of the popular education, where the idea is that everybody already knows something. So let's come together, let's put together what we all know, learn from each other, and that would encourage the participants to share with each other, to actually want to go back again to our classes. So participation was highly encouraged. They would share their experiences, recipes. They felt welcomed, more open to make a change, and to return to our classes, like I had said. And we included the 3 types of learning: visual, audio, and kinesthetic. So they were always entertained, and that helped with our teachings. We would cover the overall health as it relates to diabetes, oral care, foot health, eye health, because the idea in our culture is that it hasn't happened to me, so I'm not worried about it. But when everybody else is sharing their experiences, they're more open to the idea of change. Next slide, Hansel. We would offer these classes in Spanish mainly. Throughout the day, we had several classes going on, but we would accommodate to the participants. If they could meet after work, that's when we would meet in areas such as community resource centers or public libraries. Next slide, Hansel. The goals of these classes were to improve and maintain the quality of life, prevent complications and incapacities, improve eating habits and maintain adequate nutrition, increasing our physical activity. And, we have those participants that would say, I can't go to a gym, I don't have time, or I won't go at all. We would show them videos or leave them videos, show them resources in their area that provided free exercise sessions, the parks that have the machines already incorporated in their setup. And even we would go as far as to, just picking up the jug of water, like weights, and we would model for them anything that they were able to do without getting hurt. Next slide, Hansel. So common barriers that we would see in this program. Many of our participants before joining Nuestra Clínica del Valle were uninsured, so they would self-medicate. And the reason for this is because we live so close to the Mexican border, and our participants go over and buy in bulk what metformin or insulin in bulk, and then they're self-medicating to dosages that they don't know if are good or bad for them. It is also in our culture to do home remedies first. Let's try this before we actually go see a doctor. So we don't end up going to see a doctor till like we're feeling really sick. And that's also a barrier that we saw in the program. they would try natural products or the home remedies first. And also maybe not storing medications properly. Transportation issues and to and from our sessions, and the lack of support system. So if a mom is attending our classes where we encourage the replacement of foods, the family members may not be too willing to make a change. And that's when the promotoras would sometimes be the only person encouraging the participant to make a change. And we incorporated the family or their support system every time we would go to the home visits. Next slide, Hansel. So identified solutions to our program barriers. We had compassion funds, which were vouchers for their medical visits, and also the social worker at the clinic. Transportation services, some participants were offered transportation similar to the Medicaid transportation services, and they had that voucher to get picked up and dropped off. And then support groups and cooking classes. These were free classes that provided the participant with all the ingredients to make foods every time that they went to the class. So they would learn new ways, substitutes of foods. Next slide. These are some statistics from the program. Like I said, most of our classes and our visits were in Spanish, and we had over 700 participants enrolled, and about the support systems that would attend the classes too. We had a high participation attendance, and an overall, they made some changes and lowered their A1Cs. Next slide, Hansel. So here's a video. So overall, the goal of the program was to empower the community with their diabetes management and resources in their area, so that even after our program ended, they knew where to access these resources in their diabetes journey. I can't hear it, Hansel. I don't know about anybody else, but I can't hear it. Maybe if you go into your share settings and then share sound.
I apologize, guys. Seems that we're having some technical difficulties playing that video. I will make sure then to try to. I will include this video on the slides that on the email they will be sending out with the slides and the recording of it. It was a good video that we wanted to go ahead and show you guys, but unfortunately, it doesn't seem that we're gonna be. Let me try one more time, see if this is working. Because I can hear it on my side, but no one else can hear it, right? Chucks. Okay. All right. Nothing.
No, Hansel, do you want me to try on my end? I have it as well. Well, that's okay. Yeah, it seems that we're gonna have troubles with that. So I'll just go ahead and like I said, I'll send that video to you guys so you can go ahead and view it later on. Before we continue with the resources that we want to go ahead and offer you guys, I would like to go ahead and have you guys complete this evaluation for us. Through this evaluation is how we ensure that we are providing the right information that you guys are needing. So you can take some time to go ahead and complete. It's only 3 questions. You can go ahead and answer that for us. We would greatly appreciate that. So we'll go ahead and give some time to get some of those answers. Still have some people answering, so I'm gonna wait a few more. Trying to get a little bit more responses there. Get a few more. All right, I'll go ahead and keep that poll open, but I will continue with the presentation. So if you can go ahead and answer that questions for us, we would greatly appreciate it. At this time, we're gonna go ahead and have a little, I guess we can go ahead and open up for question and answers. If you guys have any questions that you guys would like to go ahead and ask us, if there is no questions, that we can go ahead and go back to here to the discussion, and this can guide us through this next portion. So at this time, is there any questions, comments, concerns for myself, for Selenia that you guys might have? Very quiet crowd we have today. Does anybody want to go ahead and share what your experience is working with CHWs or enabling staff has been? Or maybe let us know what some of the barriers or community faces that you feel that enabling services staff might be able to assist with now that you learn about some of those different roles that they play. Is there some barriers that you have noticed in your community? You're like, hey, you know what? Enabling services staff might assist us with this. Or share some success stories. Very quiet crowd. All right. Well, if at any moment you change your mind and you want to go ahead and mention those things, let us know. I will be moving forward with our resources. The following resource here is brought to you by MHP Salud. This is our resource on the role of CHWs in addressing diabetes. The purpose of this guide is to assist health centers and participants in identifying the roles of CHWs in addressing diabetes. This guide will provide access to information that will facilitate the identification of CHWs and their health centers and the roles in addressing diabetes self-management and prevention in their communities. And this is available both in English and in Spanish. And it's just a matter of going into that website or into our website, MHP Salud, and you should be able to find that. Another resource that we would like to go ahead and offer you guys is our return on investment educational tool. This is a free toolkit. It was created for those that understand return on investment very clearly, and also for those that are new to it and are a little bit intimidated by the concept of return on investment. The toolkit was designed to figure out the return on investment of community health worker in the program unique to your organization. And this one is also available in English and in Spanish. The last resource that we have here to offer to you guys is going to be our resource of how to go ahead and start a community health worker. if you're in the process of starting a community health worker, or if you already have one and you want to go ahead and improve it, we do offer different types of topics. They can go ahead and assist you with your community health worker profession. Things such as organizational conceptual fitness. Do you want to find out if your organization is ready to have a CHW program? Maybe you are ready to start hiring and you want to know what to look for. We provide you with some CHW pre-hiring checklist. So all that information, as I mentioned, can be found through our website. I would like to go ahead and I'll remind you guys that our session number 3 will be happening on February 9th, which is going to be Wednesday. At the same time that this session happened, we are having Jillian Anunciata from Sun River Health as our special guest for that session. The objectives for that session is the first one, to understand the role of health centers in addressing health equity. We're also going to go ahead and have a touch base on a case example of how health centers address health equity, the relationship to quality, and the population health management for patients with diabetes. And we're also going to go ahead and share tools and resources to address health equity in the relationship to quality and population health management for social and vulnerable populations. As a reminder, if you are in, are we giving up? Well, yeah, so that is it for us here today. Thank you for taking the time to join us. And we hope to see you on our next presentation, which is going to be February 9th. Same time, same link.
Thank you.